Great, so thank you for coming. Thank you for coming today and letting me speak with you. So this is going to be a short presentation on assessing for PTSD and the impact of military culture. So what I hope to do to get, that we're going to address today is to understand military culture and its impact on recovery from trauma, be able to assess for PTSD in veterans and service members, and to become familiar with treatment options and resources within the community and the VA. So this can be helpful for people that are VA providers, but also really targeted for our community providers, because a lot of times veterans often can enter mental health systems through the community where they live. And the way I think about it is that effective patient-centered care really includes cultural competency. And when we think about the military, right, that's a culture in and of itself, and is just as important the same way that you would really want to be really informed about somebody's ethnic or racial or religious or community background as well. So it's really important when you're encountering a veteran or a service member that you're familiar with how their military experiences might impact their care. And so just a brief overview of how the United States military is structured is that there's 5 main branches: the Army, the Navy, the Marines, the Coast Guard, and the Air Force. So when we think about active duty personnel, right now, actually I think the data might be from 2015, so the numbers might be very slightly, but there's about 46.5% of the active duty force is within the Army and within the Army National Guard and Reserve branches. There's about 21.7% are made up from the Air Force, 17.8% in the Navy, 12% in the Marines, and 2% in the Coast Guard. So just thinking about how, when we think about the different branches and how they're structured. The National Guard, it's run by the state, so you might be really familiar, like, Connecticut National Guard. They can be activated and pressed to serve in the Army. So what we've really seen is that there's been a lot of activation of our National Guard over the last conflicts of the last, 10, 15 years. And so in practice, they remain troops of the state, to serve the state whenever it needs them. So in terms of like disaster, community, disaster relief, and emergencies in that way. The reserves are a reserve force that augments regular forces. So reservists can get activated into their main branch as soon as they're called in on active duty. And I think it's important to kind of see the difference between active duty and guard, because that really has a big impact also when we think about how that can impact their experiences within the military, especially if they're deployed in their experiences as well, receiving services at the VA. So an active duty, they're a full-time employee, right? That's their job in their service. During deployments, they can have periods of working nearly 24 hours, 7 days a week. So lots of, during deployments, really active periods of no rest, limited contact with family, friends, long separations, whether they're on deployments or training cycles. Individuals can be assigned to different units or branches based on the need to fill a skill set. So I've worked with several veterans who were, Navy medics, right? But then they served in like other branches, or, that were maybe a Marine but went into other things as well. So it's really important to think about, when we think about community and structure, like you might have trained and been with a group, a unit the whole time, and now all of a sudden, because of your skill set, or because of the need, you get sent to be with a group of people that are, strangers for you. And then when we think about our National Guard and our reservists, is that these are more part-time employees. So a lot of times, sometimes somebody can have a period of active duty, and then they enlist afterwards into the Guard or the Reserve, or some people kind of go right into the Guard. And so this is where you might hear, serve, monthly drills and 2 weeks trainings a year, and that's when we're thinking about our Guard. They can be called really suddenly to active duty and deployments, and there can be more of like that lack of support when you go from active duty back to part-time status. So I think a lot, people that go into the Guard, they might say, I wanted to do some work, I wanted to get some help, I wanted to serve like in this way, but now all of a sudden, I joined pre-9/11, now it's post-9/11, and now I've been called to active duty, and I've been gone for 2 or 3 years. Maybe I was in the middle of starting my career, finishing college, starting a family, and now this is something that I really didn't expect, and I'm being pulled away from all of these things. And it's important to note, too, that our National Guard, this has been the longest and largest immobilization since the Korean War. So there's been a lot of our National Guard members are serving, 1, 2, 3, if not more deployments over the last years. And just to take a few minutes just to think about who is serving, so some of the demographics of our military and personnel. We have about, and this is based on 2013 data, so I looked recently at some 2015, 2016, and the numbers are basically still about the same. They only vary slightly. There's about 84% are male, 16% female, okay? And the largest percentage, 40%, are 25 or younger. And then we have about 21%, 26 to 30, 15%, 31 to 35, 10%, 36 to 40, and then 14%, 41 or older. And then racial demographics as well. It's about, the numbers are about the same now as they were back in 2013, just slight variance. But we have 71% white Caucasian identified background, 17% Black or African American, and then there's other, multiracial, Native Hawaiian, other Pacific Islander, Native American, or Alaskan Native and Asian. What we do know is that the Army National Guard, it doesn't report certain racial demographics, and the Army and Reserve also don't report certain demographics, so it could be skewed a little bit because of that. And so just to think about our veteran populations, right? So for our veterans, we have about almost 22 million veterans as of 2015. So I estimate that number has probably risen in those years since. And about 213,000 here in Connecticut. So that is, we have a really nice sized population. And as of May 2012, there were about 1.5 million unique OEF, OIF, and OND veterans that separated from active duty following a deployment. So we have a lot of veterans and a lot of need in our community to be able to give good care to these folks. So I want to spend a few minutes just thinking about what are some of those stressors that are facing our service members and our veterans that might be a little bit unique than civilian populations. So we already talked about that, we've had people that have gone on these really extended and repeat deployments, especially when compared to other conflicts. I often come across people that have served 4 or 5 deployments that lasted about a year or if not longer throughout the course of their military career. Within that, so the constant threat and loss of life, a lot of inner conflict, so some spiritual dilemma, changes in schemas, how we see the world, ourselves, when we talk about moral injury, right? And then having a lot of wear and tear, a lack of control. Always having to, that 24/7, right? Always having to go out, not really getting sleep. And then even if you do have time dedicated to sleep, it can be really difficult to sleep, right? Because it's kind of always that threat, I have to stay on alert, I have to be on guard. There's also been a lot of work within the VA system to, recognize, assess for, and think about sexual trauma and how that impacts our military and our veteran populations, which we'll actually talk about in a few slides from now about how to ask about that and how to assess for that. Accidents and injuries in a different way than maybe civilian populations might be exposed to. A lot of unpredictability. So sometimes people will get sent on missions or deployments, they don't know where they're going, and then, they can't, and even when they do know where they're going, they can't necessarily tell their family, their loved ones at home, and so there can just be a lot of worry. You have somebody at home that doesn't know where you are for 6 months, and that can be really challenging for the family structure. And biological. So you have somebody that's here, it's winter in Connecticut, and now they're shipped halfway across the world. They go to Afghanistan, it's the middle of summer, they were just in 15-degree weather, and now it's 100 degrees in the hot. And when we think about chemicals, food, and water exposure, somebody had pointed out this to me that I found really telling is that, so they get, water gets shipped over, plastic water bottles, and then it sits, right? Sits in the scorching heat for weeks, months, and just thinking about plastic and what happens to plastic and the possible chemicals that it can leach. And while maybe we don't necessarily know, but those are all things to think about. It's how can some of the things that we might take for granted, just having clean, fresh water, yes, it's clean, fresh water, but what happens when it sits in a plastic bottle at 120 degrees for months on end, right? And then chemicals too, right? There's a lot of, we know about burn pits, about other chemical exposures and things that folks are breathing in that can have a really big impact on their health and their well-being. And financial and economic strain, I think, this really connects back to that idea, what if somebody's here and they're working full-time, supporting themselves or other people, and now they have to go on a deployment, right? And there could be a loss of income in that as well, and that could really impact them and their family. Lack of personal space, privacy, tight quarters, lack of support and alienation in the civilian world, right? So feeling like they come back to a place where no one really gets them, they don't feel like they fit in, they've been gone. The rest, they might have graduated high school with their buddies, their friends went to college, they went to war, they went to the military, and now they come back and they're like, and their friends are kind of moving on with their life in a sense, but they feel kind of like they're stuck back, in the 18, 19-year-old self. And having the access to job school and healthcare, people get amazing training in the service. They're very, very skilled, very, very intelligent, but sometimes, civilian employers just can't really get how those skills can transfer over to positions that they have opening. And so although there's stressors, there's also a ton of protective factors, right? The military really has some nice, they offer and they give a lot back to folks that do that. So there's a shared set of beliefs, so a sense of community. There's a shared understanding of the mission. So a lot of people, even though they've been through these very stressful times, they often say, like, I'd go back in a heartbeat because I had meaning, I had purpose, I knew what I was doing. I felt like I belonged. It's characterized by that really high level of cohesion, feeling protected. Is anyone familiar with Sebastian Junger and his work? Yeah. So there's a couple TED Talks, and Rest Repo is also a documentary that he's done. And there's this great one that talks about why veterans miss war, and it really says that, one of my favorite quotes is, brotherhood is a mutual agreement in a group that you put the welfare of the group, you will put the safety of everyone in the group above your own. In effect, you're saying, I love these other people more than I love myself. And the biggest loss is losing that brotherhood. And what that feels like for folks when they come home, and to not have that community, and to come back to a community or a culture where it is very kind of, people might be out for themselves more so than the community of everybody else. Which makes us, and then we're going to kind of shift gear to talk a little bit about PTSD. So those are some of the ways, just to think about how the military might impact someone's experience of trauma and recovery from trauma, right? So they're faced with all of those stressors, and they have all these protective factors that coming home, a lot of those are missing. We used to think that trauma was this very rare thing that happened, but now we know that it's pretty common, that about 50 to 75% of adults experience trauma at some point in their life, and 7 to 10% of the US population will have PTSD at some point. Many can also suffer from other disruptions as a result of trauma, so there could be other psychiatric diagnoses, marital, occupational health problems, and in any given year, about 8 million adults in the US have a diagnosis of PTSD. But, we think that's only a small portion of those who's actually gone through a trauma, so we know that recovery happens, right? If we have this big percentage of adults that develop it, but only 8% develop PTSD, or 8 million adults develop PTSD in a given year, we know that there's ways to help facilitate that recovery process. And about 10% of women will develop PTSD sometimes in their life, compared with about 4% of men. And some of the reasons, actually, I'll ask you, what are some reasons you think why that might be the case? Any thoughts?
Well, one thing that comes to mind is just the greater rate of sexual trauma that women might experience compared to men.
Absolutely, absolutely. And that's one of the biggest things, is that they're more likely to experience that. And we also know that sexual assault is more likely to cause PTSD than other events. And women are more likely to blame themselves after a traumatic event happens. And so those things combined are some of the, they're not that's the only reason why. There's probably many other, but those are some of the ways that we conceptualize and think about why that's the case. Yeah. Oh. Sorry, just click through. And so like we said, most people go through trauma will not get PTSD, but there are some risk factors why you might be more likely to develop it. And so we're not going to go through all of them, but if you look at this list, a lot of that really coincides with the stressors that one faces from, their experiences in the military, especially in deployments, right? So we can really see how those can really carry over. And then there's some additional kind of reasons why too when we think about other circumstances that might lead to a higher risk of developing PTSD. So recent stressful life changes, little support from family or friends, earlier life-threatening events or earlier traumas, right? And there's many, many reasons why people join the military, but some of the reasons I hear is like, I had a really difficult childhood. And so I joined the service as this way to, do something better with my life, to get out of a poor community, to be able to get a chance at education and, more culture and experiences. And then so having that earlier childhood experience and then re-traumatization within the military. Yeah. So this just talks about the differences by service era about veterans that develop PTSD. So this is just for you to have to kind of reference those statistics if you're interested. And again, we know that there's a lot of people that don't receive services, right? So these statistics only account for those that receive services within the VA or are screened through the DoD. And so I really want to think about, assessing for trauma, because if we don't ask, they won't tell, right? So we know that many people can experience more than one type of event or more than one event of the same type. So it's really important to think about the lifespan, when we're asking questions about assessing for trauma. So, are there any specific intense or difficult experiences that stick with you? A lot of times people have experiences that they don't name as trauma, but as clinicians, we can kind of recognize that and see it as trauma. But a lot of people don't come to therapy saying, I really want to work on this trauma. They come to therapy because they can't sleep, because they're having intrusive memories, because they're functioning, they've lost a lot of relationships. They're experiencing a lot of anger. And so we want to see, okay, well, what might those experiences be that are contributing to those symptoms and those changes in functioning? And it's really important, to really think about asking about sexual trauma. So we want to always assess for MST. About 1 in 4 women and 1 in 100 men report experiencing military sexual trauma. And again, that only accounts for those that are receiving services at VA and that actually report. So we would imagine that the prevalence of MST is significantly higher, given that it's something that somebody might not be so forthcoming in wanting to share. And a lot of veterans that also aren't receiving services. So, and it's really clearly, like when we assess for suicide, we just kind of say it as it is, right? And the same thing with military sexual trauma. So did you ever receive uninvited, unwanted sexual attention, such as touching or cornering, pressure for sexual favors or verbal remarks? And then even asking, did someone ever use the force of threat or force to have sexual contact with you against your will? And I think too, although people may not, if you see someone for the first time, they don't know you, there's not really that trust or that therapeutic alliance built yet, so somebody might not be so forthcoming to answer those questions directly with you in that first assessment. But if you ask these things empathically, non-judgmentally, in a really safe way, and you continue services with that person, I bet that over time, that it would really help them be able to feel like this is a safe place that they could be able to disclose those things with you. So just be curious, really asking about, what was your military experience like? What led you to want to be in the military? How long was your service? What was your deployment history? Somebody who had 19 years in, well, what happened in that 19th year? Like you were working, towards retirement, what was going on? Or if somebody had a shorter, what was that like for you? What led up to your decision to not enlist again? Or what was, behind that discharge status? And also asking, what was it like when you came home? If we know that the loss of that brotherhood, of that culture, that camaraderie can be so difficult for many people, what was it like when you came home? Were there supports there? Did you find a job? Were there things that mattered for you when you came home? And if you don't know what something means, just ask. There's so many times where I'll interview and assess people and they'll talk in their lingo and their acronyms and I don't know what it means, but I think that it's really important just to ask because it shows that you're curious and you care and you want to be able to speak that same language with them. Mm-hmm. And so when we're talking about assessment measures, there's so many different things that we can do to assess for trauma exposure. So these can be self-report measures that veterans have some time. There are things that you can ask in a clinical interview. And so I just listed a whole bunch on here for you if you wanted to, a lot of these are accessible online through the National Center for PTSD. So just really thinking about which assessments make sense and feel comfortable for you, and within also the environment in which you work. And again, like we have 2 whole pages, so there's lots of different good assessments. Most typically, we see people using the LEC, the Life Event Checklist 5, and combined with the PCL. So the LEC will help to identify if there's a criterion A, and then the PCL will assess for the symptoms that are impacting the person in that month period of time. And so in the clinical interview, right, there's a couple different ways to assess for PTSD, but really our gold standard is the CAPS-5 that is often used for diagnosing PTSD. So the PCL or other symptom assessments, self-report assessments, can be helpful to get a gauge on current symptoms, but sometimes standing alone, you need some more information to really confirm that diagnosis. And so when we think about the CAPS-5, it's a 30-item, it's a structured interview, so you can use it to really target the onset and duration of symptoms, how they impact someone's functioning, their social and occupational functioning, the severity of those symptoms, and you can use it to make a current or a lifetime diagnosis, which makes it, and it's a really, really valid, reliable tool to use. And so if you are a clinician within the VA, there are training opportunities through TMS to be able to get the training needed to administer the CAPS-5, and if that's something anyone is interested in, I'd be more than happy to talk about that. And I really appreciate this quote. So PTSD therapy, it helps change your relationship with the trauma. It's not for erasing the memories, right? Because we know we can't go back. We can't, as much as I wish that we could just wipe that memory away, we can't. But what we can do is facilitate that natural recovery process and help people gain a new understanding and meaning of what they've experienced. Because PTSD used to be thought of as untreatable, but we know that people get better. We know that recovery is possible. And it happens often in the relationships. Right? So to be able to have that relationship, to build trust again, to be able to experience that with another person. And there's so many, there's evidence-based treatments that work, right? So we know that there are treatments that can help regardless. It says early intervention can be crucial, but really doesn't, somebody can come in 30, 40 years from the time of that event and get better. So when we think about barriers to treatment, right, especially when we're thinking about our military populations, there might be the perception of being seen as weak. There might be a fear that leadership or others might treat me differently. They might lose confidence in me. It might disrupt my career. And there's also, remember, that sense of, the mission is first, I'm second. So if I'm to take myself out to get this treatment, what would that mean for the other men and women in my unit, right? And so once we get somebody, right, who's saying like, hey, I've been going through this, I want to feel different, I think I'm ready. You've assessed, there's a clear diagnosis of PTSD, and they're ready to come in. There's a lot of treatment options. And so we have our standard, our EBPs that we talk a lot about within the VA system. So prolonged exposure, cognitive processing therapy, EMDR. So some of the top 3 EBPs for treating PTSD. We also have other treatments that are trauma-informed, right? So such as present-centered therapy, stress inoculation, TFCBT. So we know that, especially with those first 3, like those treatments work when they're delivered and when people do them, right? According to the protocol, is that people get better, right? We've seen symptoms significantly reduced, where many people sometimes after therapy, they no longer actually meet the criteria for PTSD. And for anyone who is delivering trauma-focused therapies or working with veterans and service members with a history of trauma, is that it's really tough work. It's really, really tough work. And so the expectation that we can be immersed in suffering and loss daily and not be touched by it is as unrealistic as expecting to be able to walk through water without getting wet, right? So it's really important to find support, good supervision, being aware of some of your red flags of if you're starting to feel some compassion fatigue, vicarious traumatization, empathic strains, burnout. So really starting to pay attention to how that's impacting you and, really staying almost like a step ahead of that and really engaging in self-care is so important in the work that you all are doing. And just briefly, so you have this, I wanted to just go over some quick resources that you can have as providers. So this is accessible for you whether you are a VA provider or a provider in the community. The Center for Deployment Psychology has some great courses on military cultural competence. They also, there's another, it's not listed on here, but if you go to www.mentalhealth.va.gov/community providers, it's an amazing toolkit of resources for folks that work with veterans or people in the military, and it's great for folks that aren't within the VA system that might have limited access to that information. It's all free, and it's all there. And we also have our National Center for PTSD, which is, I mean, by far one of the best resources I've ever encountered, again, for VA providers, but also people in the community. And it could be for folks that experience PTSD that is non-military related as well. So they do a lot of research and education. You can call the National Consultation Program if you are a provider that treats veterans, and that consultation program can talk with you individually about any challenging cases or questions or resources, or like, hey, I have this veteran who really wants to go to this residential program somewhere, but I don't know where or what that would look like, and they can help walk you through that. So really encourage you to use those resources whenever you need. They're available, again, within the VA and within the community. So with that, I wanted to, there's information on the consultation program, and resources within Connecticut. So we have the VA Connecticut, we have our vet centers, which are part of VHA, just a little separate from our main campuses, and they can provide individual group family counseling for folks who have combat related or during times of wartime era service, or for veterans who have history of military sexual trauma. We also have the Starlight Military Program here in Connecticut. So that is non-VA affiliated, but they really have this program that focuses on serving our military populations and veterans. And then Courage Beyond is another resource that helps no-cost programs and services for people with PTSD and other invisible wounds. So I just wanted to ask if anybody had any questions or thoughts or remarks that I could help with.
So I had a question.
Yeah.
So what if you're working with a veteran and they say they don't want to talk about their trauma, that they're recognizing some symptoms of PTSD, but they're not ready to talk about it? Do you have any suggestions?
Yeah. And I think I often use the analogy like that we're in the car and you're in the driver's seat, and so your foot is on the gas and the brake, and I'm going to encourage you, and then I'm going to provide a safe space for you to do that. But it might, maybe we need to, that you have that control, right? So we think about PTSD and trauma, so much of it is a loss of control, and if we're trying to push for something, it might actually end up pushing the veteran further away from us. But I think also providing, the rationale why it might be important to disclose that, information. So saying like, hey, you've been struggling with these things, but I know that there's a way to feel better. And so what would it look like if you were to disclose this? What would that mean to you? What would it mean to be able to kind of wake up and have a good night's sleep, or be able to go kind of back to doing the things that are really important or meaningful for you? And so sometimes giving a nice rationale or some of that motivation can help people feel like they're in a safer place to be able to disclose trauma. Yeah. Yeah.
What about a veteran that is considering entering treatment for PTSD, but is not sure about whether to do an outpatient program, inpatient?
Yeah. So the first thing that comes to mind is that we have this great resource called the Treatment Decision Aid, which talks about the differences between, what would it be like going to a residential versus outpatient? What are the different treatments available to me? And I think really talking with them about their individual and their unique circumstances. Somebody might be in an area where where maybe they're in a more rural area and they don't have access to the EBPs or to really good PTSD treatment, and so that might mean that they might have to go somewhere a little further away, like a residential, for the good care. But we also know that the more that these treatments are getting disseminated, the more accessible they are for folks. We can deliver them via telemedicine. So if somebody's at home and they're like, no, I can't go away to treatment, I have kids, I got to help out, I can't leave my job for 3 months, maybe they have access to a CBOC and they can do telemental health, or there's a provider within their community that you can find. So I think just really talking about their options and the unique circumstances that might kind of be lending them to go one way or the other between outpatient or inpatient. Yeah. Okay. Thank you, everybody.